Welcome to this lecture on elbow and forearm pathologies. The elbow may seem like a small region, but it plays a major role in force transfer between the shoulder, trunk, wrist, hand, and sport implement. Throwing, gripping, lifting, blocking, and falling on an outstretched hand can all stress different tissues. As we move through the lecture, keep asking, where is the pain? What activity or mechanism created it? And are there red flags, such as deformity, major motion loss, numbness, weakness, or neurovascular compromise? The goal is to build a safe reasoning process for evaluation, referral, early management, and return to sport. These objectives give us the roadmap. First, we will identify common causes of elbow and forearm pain in both throwing and non-throwing athletes. Then we will use location and mechanism to separate tendon, ligament, nerve, and bony disorders. The main clinical mindset is location-based reasoning. Medial pain in a pitcher raises concern for UCL stress, flexor-pronator overload, or ulnar nerve symptoms. Lateral pain with gripping often suggests lateral epicondylalgia. Posterior swelling points toward the olecranon region. Diffuse pain after trauma, especially with deformity or motion loss, requires a lower threshold for referral. Use this anatomy slide to orient the elbow and forearm before moving into diagnoses. The region includes the humeral ulnar joint, humeral radial joint, proximal radial ulnar joint, collateral ligaments, common flexor and extensor origins, biceps and triceps insertions, and important nerves. The ulnar nerve sits behind the medial epicondyle, so tingling into the ring and little fingers matters. The radial head is important after a fall because fracture can limit pronation and supination. Do not treat the elbow as only a hinge. It also supports rotation, grip, and force transfer into the hand. The history should quickly narrow the differential. Ask whether pain is medial, lateral, posterior, or diffuse. Clarify whether symptoms began with throwing, gripping, lifting, a fall, direct contact, or a gradual workload increase. In throwers, ask about pitch count, velocity, command, fatigue, and pain during late cocking or acceleration. In non-throwers, ask about racket use, lifting, typing, gripping, and work demands. Also ask about popping, locking, stiffness, swelling, numbness, weakness, and loss of rotation. Pain with gripping leads you somewhere different than "I felt a pop while throwing." Observation, motion, and palpation form the base of the elbow exam. Inspect carrying angle, swelling, bruising, resting posture, olecranon contour, and deformity. A swollen posterior elbow may suggest bursitis, while deformity after trauma raises concern for fracture or dislocation. Assess elbow flexion and extension, then forearm pronation and supination. Painful loss of rotation after a fall is especially concerning for radial head injury. Palpate the epicondyles, common flexor and extensor origins, UCL region, olecranon, triceps insertion, radial head, and cubital tunnel. Add resisted testing and neuroscreen as indicated. Choose exam tools based on the clinical question. Lateral pain with gripping fits resisted wrist extension, resisted middle finger extension, and extensor origin palpation. Medial pain in a thrower requires UCL palpation, valgus stress assessment, moving valgus stress testing when appropriate, and workload history. Tingling into the ring and little fingers shifts the exam toward ulnar nerve screening with sensation, intrinsic hand strength, and cubital tunnel palpation or Tinel sign. Posterior swelling starts with inspection and olecranon palpation. After a fall, radial head palpation and forearm rotation help screen fracture concern. Now we will move into common elbow and forearm disorders. Separate the patterns as tendon, ligament, nerve, posterior swelling, or traumatic bony injury. Tendon problems usually follow repetitive loading and reproduce with resisted muscle action. Ligament problems often involve valgus stress, especially in throwing athletes. Nerve problems bring numbness, tingling, or hand weakness and change the urgency. Posterior swelling may be obvious before testing. Traumatic injuries after a fall or collision require caution. For each pathology, connect location, mechanism, symptoms, palpation, resisted testing, and sport demand. Lateral epicondylalgia, often called tennis elbow, usually presents as lateral elbow pain with gripping, lifting, or resisted wrist extension. The tissue involved is commonly the common extensor origin near the lateral epicondyle, especially the extensor carpi radialis brevis region. This is better understood as a load tolerance problem than simple inflammation. The patient may report pain opening a jar, holding a racket, shaking hands, or lifting with the palm down. Exam findings often include lateral epicondyle tenderness, pain with resisted wrist or middle finger extension, and reduced grip tolerance. Management uses activity modification and graded tendon loading. Medial epicondylalgia and flexor-pronator overload involve pain near the common flexor origin. Symptoms may be provoked by resisted wrist flexion, pronation, gripping, or throwing. In a non-thrower, this may reflect repetitive hand use or lifting. In a thrower, medial pain deserves extra caution because the flexor-pronator mass helps protect against valgus stress and may overlap with UCL irritation or ulnar nerve symptoms. Palpate the common flexor origin, test resisted wrist flexion and pronation, assess valgus sensitivity when appropriate, and screen the ulnar nerve. Isolated overload may respond to loading. Instability or nerve symptoms may need referral. UCL injury is a major concern in overhead athletes because the ligament resists valgus stress during throwing. Symptoms often appear during late cocking or acceleration. The athlete may report medial elbow pain, a sharp pain during a throw, reduced velocity, loss of command, or difficulty finishing pitches. Examine UCL tenderness, valgus stress sensitivity, and moving valgus stress when appropriate. Also screen the flexor-pronator mass and ulnar nerve because these can overlap. High-grade instability, a traumatic pop, persistent throwing pain, or failure to progress with appropriate workload reduction warrants sports medicine referral. Ulnar neuritis and cubital tunnel symptoms involve irritation of the ulnar nerve at the medial elbow. The key symptom pattern is tingling, numbness, burning, or altered sensation into the ring and little fingers. The patient may also describe grip changes, hand weakness, or symptoms that worsen with prolonged elbow flexion. In throwers, valgus stress and medial elbow irritation may contribute. The exam should include ulnar distribution sensation, intrinsic hand strength, grip comparison, cubital tunnel palpation, and Tinel's sign when appropriate. Persistent, worsening, or function-limiting neurologic symptoms should not be treated like simple soreness. Olecranon bursitis and posterior elbow pain often show up visually. The olecranon bursa can become irritated from direct pressure, repeated leaning, trauma, or infection. A patient may present with swelling over the back of the elbow, tenderness, warmth, or pain with pressure. Not all posterior pain is bursitis. Triceps tendinopathy, triceps strain, posterior impingement, olecranon stress injury, or fracture can also contribute. The most important screen is infection. Redness, warmth, fever, drainage, rapidly worsening swelling, or systemic symptoms raise concern for septic bursitis and should prompt referral. Radial head fracture and traumatic elbow injury should be considered after a fall on an outstretched hand, direct impact, or traumatic twisting injury. A classic clue is pain or difficulty with forearm pronation and supination, especially with radial head tenderness. The patient may also have swelling, guarding, effusion, or inability to fully extend the elbow. Deformity, severe pain, major effusion, neurovascular change, or suspected dislocation requires urgent referral. Avoid aggressive testing when fracture is possible. Protect the region, assess neurovascular status, immobilize when needed, and refer for imaging or medical evaluation. This section brings the conditions together. Start with location. Medial pain points toward UCL stress, flexor-pronator overload, or ulnar neuritis. Lateral pain points toward epicondylalgia, radial tunnel-type symptoms, or radial head injury after trauma. Posterior pain points toward olecranon bursitis, triceps involvement, impingement, or direct trauma. Diffuse traumatic pain with deformity, motion loss, or neurovascular signs raises fracture or dislocation concern. Then connect location to mechanism, palpation, resisted testing, neurologic findings, and sport demand. That keeps the exam focused and safe. Use this matrix as a quick clinical checklist. Medial elbow pain in a thrower should include UCL stress, flexor-pronator overload, and ulnar nerve irritation. Lateral pain with gripping and resisted wrist extension often supports lateral epicondylalgia, but trauma or rotation loss brings radial head injury into the differential. Posterior swelling after direct pressure suggests olecranon bursitis, while posterior extension pain may involve triceps or impingement. Diffuse traumatic pain, deformity, major swelling, neurovascular symptoms, or loss of motion should lower the threshold for urgent referral. In this case, a baseball pitcher has medial elbow pain during late cocking, reduced velocity, UCL tenderness, and symptoms with valgus stress. That pattern raises concern for UCL involvement rather than simple soreness. Ask about pitch count, recent workload spikes, fatigue, command changes, and whether pain continues after throwing. The exam should include UCL and flexor-pronator palpation, valgus stress assessment when safe, ulnar nerve screening, grip and forearm strength, and comparison to the other side. Initial management should reduce throwing load and protect the elbow. If instability remains likely, refer. In this case, a recreational tennis player develops gradual lateral elbow pain with gripping and backhand strokes. There is no trauma, and the neurologic screen is normal. This pattern fits lateral epicondylalgia, a load tolerance issue of the extensor origin. Confirm tenderness near the lateral epicondyle, pain with resisted wrist or middle finger extension, and grip-related symptom reproduction. Since there was no fall, deformity, major swelling, or loss of forearm rotation, fracture concern is lower. Early care focuses on modifying aggravating grip load, progressive wrist extensor strengthening, and gradual return to racket demands. Management depends on tissue type and risk. Tendon problems usually improve with graded loading, activity modification, and workload correction. Ligament instability, especially UCL concern in throwers, requires caution because throwing places high valgus stress on the elbow. Nerve symptoms require monitoring because persistent numbness, tingling, or hand weakness changes urgency. Traumatic injuries with deformity, swelling, neurovascular changes, or motion loss require protection and referral. Return to sport requires ROM, strength, grip capacity, confidence, sport-specific tolerance, and no concerning instability or neurologic findings. The key takeaway is that elbow evaluation becomes stronger when you use location-based reasoning. Medial symptoms in throwers require screening for UCL stress, flexor-pronator overload, and ulnar nerve involvement. Lateral pain with gripping often suggests extensor tendon overload, but nearby nerve and joint contributors should not be ignored. Posterior swelling can often be identified visually, but infection signs change urgency. Traumatic loss of motion, deformity, or neurovascular change should always lower the threshold for referral. When findings do not line up, broaden the differential and protect the athlete. These references support the anatomy, examination principles, throwing-related elbow concepts, tendon loading strategies, and sports medicine reasoning used in this lecture. Use them to review UCL injury, lateral and medial epicondylalgia, ulnar nerve symptoms, posterior elbow conditions, fracture screening, and return to sport planning. A strong elbow evaluation combines careful history, location-based differential diagnosis, focused examination, red flag screening, and evidence-informed management. That approach helps you move from memorized diagnoses to safer clinical decisions.